Good. I'm so sorry, people. Okay, so here we are again. So they missed that exciting story. So the liver has 4 lobes. You say to yourselves, well, look at this. There's only 2 lobes. But if you flip it over, then each of these 2 lobes has another midline going through it. So in actuality, there's 4 lobes, but when you look at the top, there's only 2 lobes. So depending on the textbook that you're reading from, it may say 2, it may say 4, there will be not a test question. So don't worry about it. Anyway, the thing about the liver that is so interesting is that it's a very effective organ because it does several different purposes. It has several different things that it has to do, and you don't need the entire organ. It's so efficient in what it does that you can lose a lobe and still have enough. My daughter was in failure and had cirrhosis, and technically they were trying to decide whether or not she should have a transplant, but even with her enzymes and the cirrhosis, the amount of cirrhosis that was going on, there was enough functioning liver that she didn't have to have a transplant. She just had to have that medication. So you respect the liver. And then underneath here, you're going to see that this is the gallbladder that stores bile. The liver makes the bile, the gallbladder stores it. So, and here we have another wonderful picture from the GI system. You have the liver here, you have the gallbladder here, but then we have the pancreas we have the stomach, it's this J-like tube here. But the pancreas is this kind of banana-looking organ here, and it has digestive enzymes that help with the digestion of food, but it also has the little glands that make insulin. So when a person is eating and the food goes or the chyme goes from the stomach into the duodenum, that triggers the gallbladder to release some bile and the pancreas to release digestive enzymes. Now, what is interesting about this is that there is one bile duct that comes off the gallbladder here and is right here. But then the pancreas with its digestive enzymes and insulin goes right here. Okay? So it's a common bile duct. It's used to dump the digestive enzymes into the duodenum. Number 1, to reduce the acidity in that chyme as it enters the small intestines, and digestive enzymes which break down the food even more. And so, but they go through this common bile duct. And look at how tiny it is. It's really, really tiny. So if it gets blocked for any reason, then you are going to have a backup here and a backup here. And what happens here is that those digestive enzymes go back up here into the pancreas and it starts auto-digesting itself. So when somebody has pancreatitis, oh my gosh, they are nauseated, they are vomiting, they cannot eat one thing because what happens when you eat? It triggers the release of some of those digestive enzymes as that food enters the duodenum. So, this is one of my most favorite parts of the whole lecture. So be prepared, be prepared, be prepared. Here we go. So the liver has a huge blood supply to it. So if we go over here, you are going to see the hepatic artery. This comes right off the aorta here, and it's feeding the liver, and just the hepatic artery is dumping 400 milliliters of blood into the liver. That's a lot, don't you think? that's not all. So look at right here. So it goes into the liver here, but we just talked about the intestinal tract, and look at all these veins that are coming off of the digestive tract. Now remember that you've got 25 feet, 22 to 25 feet of intestines here. We're not talking about the esophagus, we're not talking about the stomach, we're just talking about the intestines here. And every single milliliter of, or millimeter of that intestine has a blood supply going to it. And so all that blood supply is going to come off what we call the portal vein, enter the liver through the portal vein. So it's got all these teeny tiny venules that go into upper, bigger veins that will finally dump into this huge portal vein, which dumps into the liver. But look at how much it dumps. 1,000 milliliters per minute, people, per minute. We have 400 milliliters up there. You think, ooh, that's a lot per minute. Now we've got 1,400 mils of blood dumping into the liver per minute. Now, one thing that all that blood does, even deoxygenated blood still has oxygen in it. But between the hepatic artery and the portal vein, it's supplying, those two blood supplies are going to, the portal vein is going to, itself is going to supply 60% to 70% of the oxygen required by the liver to meet its metabolic processes. So it's a huge, this amount right here, this portal vein amount, 1,000 milliliters per minute, is a huge amount of blood. And do you understand why a person that comes into the ER from a motor vehicle accident and has a liver lac, that everybody's a little concerned about hemorrhage? Because of all this blood. It's just absolutely amazing. And then your hepatic veins take the blood out of the liver after they've done all their little work, and we're going to talk about everything it does, puts it back into the inferior vena cava, which takes it back up to the heart. It's a lot of blood, people. It's a lot of blood. So, there's two different types of cells, and it really doesn't matter. Please don't spend a lot of time on these. The endothelial cells and the Kupffer cells, which do a lot of the liver's work here that we're going to talk about. We talked about bile ducts just briefly before, that bile is formed by the hepatocytes, and it flows into the common bile duct, which is right here. And then the pancreatic juices come up to the common bile duct. And there's a sphincter avoidant. You don't have to know the names of these things, but you have to understand the anatomy when you see it and what's going to happen when we talk about some disease processes. So when the sphincter avoidant here, which opens up to the digestive system, then when that opens up, then when it closes up, the bile will go back to the holding storage unit for bile, which is the gallbladder, and the stop of pancreatic juices, or the flow of pancreatic juices stops. So let's talk about the different functions of the liver here, which are really, really important. So first of all, we talked about the liver, that it produces bile. And as it produces bile, the bile has a lot, it's alkalytic. And what it's trying to do, you have all this chyme that has come through the duodenum, and it's very acidic. So the bile is going to be very alkalytic, and we're trying to neutralize the flow of the chyme through the intestine so that it's pretty neutralized. it's very important that we have that alkalitic juices so that it reduces or neutralizes the acidic secretions from the stomach. The liver will also synthesize protein and clotting factors. Again, vitamin K is metabolized in the liver. And if you don't have that metabolism going on, you're going to have coagulation issues. You're not going to have any you're not going to have any coagulation. You're going to be a bleeder. It builds carbohydrates from protein, so there's a conversion process that goes there. It converts sugars to fat, it converts fatty acids to ketones, stores vitamins and minerals, and it changes ammonia to urea. And it does metabolize different drugs that I'm sure you've talked about already in pharmacology. So let's talk about some of these things. First of all, it produces bile. So what happens here with the production of bile is that you have a red blood cell that is produced down in the bone marrow, and that can be produced in the, like I said, in the large bones of the bone marrow. But how long does a red blood cell live? We talked about this the other day. 120 days, exactly. So, and it has a natural dying process. And what happens here is the red blood cell will lyse. And then you have this breakdown of hemoglobin, and the hemoglobin will then convert to biliverdin. And what happens here is that free bilirubin then breaks down biliverdin breaks down into free bilirubin. And what free bilirubin does, it attaches to albumin. And then the albumin there is absorbed by the hepatocyte. And then once it goes through the liver, it becomes conjugated bilirubin. So you need to know the two differences between free bilirubin and conjugated bilirubin. Another name for free bilirubin would be indirect bilirubin, and another name for conjugated bilirubin is going to be direct bilirubin. And you go, that's a little confusing here. Okay, so you have the breakdown of your red blood cell. And part of the byproducts of that lysing red blood cell is going to be hemoglobin and biliverdin. And biliverdin will break down even further into bilirubin, which is free. It's floating, it attaches to albumin. And then that albumin that has the free bilirubin enters into the liver, and the liver does its little work there, and it excretes conjugated bilirubin. We got all that? So if what happens here, that if you have a patient that has developed some kind of gallstone, which obstructs the common bile duct, then what you're going to have here is this backup of bilirubin building up in the blood. So what happens here? Are we going to have a buildup of direct bilirubin or indirect bilirubin? Or, if it sounds better, free bilirubin or conjugated bilirubin? Okay, if the common bile duct is backing up, we're backing up here. Well, the thing about it would be free. Yeah, your free bilirubin values are going to get higher in the blood because the blood is backing up into the liver here. The liver is not able to do its stuff. direct. Now, the thing about it is that you got to understand what's going on here too. Where is the problem happening? So the problem is happening after some of the bilirubin gets through the liver. So you're going to have conjugated bilirubin, but it's obstructed. It doesn't get out into the blood because it's obstructed at the common bile duct. So conjugated is going to be elevated as well. But it's not an issue with the liver. It's an issue with the common bile duct. No, not necessarily, no. Okay, so what happens with cirrhosis of the liver is the hepatocytes, which do most of the work that we're talking about here, do not work anymore. So as free bilirubin enters the liver that is cirrhosed, then the liver is not going to get, the blood going through the liver is not going to get processed. And so when the bilirubin is excreted, it's going to be free bilirubin because the liver couldn't do its job. So is free bilirubin going to be elevated? Yes.
So it's not like the free bilirubin is down for it's just the blood test.
Well, it requires albumin to be excreted. So what happens when you have free bilirubin elevated in the blood? Things are going to start changing. What color do you think your stools are going to be?
White.
Exactly, clay colored, because bile is what makes your stool brown.
Yeah. Bile brown.
All right, we can excrete that free bilirubin, so it starts permeating some tissues here and ends up in your skin. What happens to your skin? Starts turning yellow. And the color of yellow is highly dependent and corresponds or correlates to the level of bilirubin that is in the blood. So you can be slightly yellow. You'll have yellow sclera and all kinds of things. Or you can be a really deep orange, which means you're about ready to bite the dust. It can be really, really bad. Okay? So does that make sense? And I don't think I said something right. What prompted me saying something right, not right, or thinking that I didn't explain it right when Kim goes, I don't get this, you've lost me. So let me repeat that because I don't think I explained it correct. All right, so free bilirubin in a normal situation, red blood cell lysis, you have hemoglobin, hemoglobin's breaking down to biliverdin, biliverdin breaks down to bilirubin. Free bilirubin. Free bilirubin will attach to albumin, go through the liver, and become conjugated bilirubin, which then goes down into the gallbladder where it's stored, and then as a person eats, it travels through the common bile duct into the duodenum and travels with the time there. All right, so that is normal. So if the common bile duct gets occluded, it's not getting to you're excreting it from it's draining from the gallbladder, but it can't get through the duct that leads to the duodenum. So it still does back up. So you're going to have a slight elevation of free bilirubin because it's working. The red blood cells are lysing still, But yeah, but you're not going to have conjugated bilirubin floating around anywhere or being excreted. So there's going to be a decline in conjugated bilirubin. And I think before I said that it was elevated. I don't know what I said. I just didn't sound right. I'm clarifying now. So go with me. However, if the liver is cirrhosed, we're going to talk about reasons why it would get cirrhosed, but those little hepatocytes become nodules and they don't do the function that they're supposed to. And so as free bilirubin enters the liver, the hepatocytes do not convert it, and so it comes out as free bilirubin as well. Okay.
Would also be elevated?
Slightly elevated, slightly, because it's working and we're backing up, but we have free bilirubin, that's there, that's going through the liver, but the conjugated is going to be slightly elevated. Because there's going to be there's not all parts of the liver that are, yeah, you're right. So it's not going to be elevated. It's going to be the same or less. Should we do it one more time?
No, I get that. The thing, I was just confused by you saying it was elevated and conjugated if it's blocked.
Abort. Forget all that kind of stuff.
I get it. You're good.
I know. I need a picture in front of me too to keep me straight someplace. I'm trying to think how I totally confused everybody, but I'll try and clear that up when I'm doing the review to make sure you all know what you need to know so that it's clear. All right, another thing that hepatocytes do is a protein synthesis. So what happens with protein synthesis, that there are certain proteins that the liver secretes. Number one, it secretes albumin. Number two, it secretes fibrinogen, which is needed for clotting. Number three, it will secrete most clotting factors, which are proteins. So now we've got all this problem here, and vitamin K is metabolized in the liver. So do you think if there is a cirrhosis liver that there is going to be bleeding problems? Absolutely. Will the PT, be elevated or low? It'll be elevated. It'll be really, really high. Why? Because it takes forever to clot, if it clots at all. Now one of the proteins that the liver secretes is albumin. So if we have a cirrhosis liver, are we going to have enough albumin in the blood? No. Exactly. That's exactly right. And that's my very next sentence. Is that if you do not have enough albumin, then you're going to have blood pressure problems because albumin is required for the oncotic pressure at the capillary levels. So if you have insufficient albumin, you're not going to have that oncotic pressure. Thus, when the blood goes out from the arterial side of the capillary into the tissues, there's not enough oncotic pressure change on the venous side of the capillary to bring fluid out of the tissues. So do you think you're going to have edema? This might even cause enough of a fluid shift that you're going to have ascites. So this is one of the reasons why you have ascites, is because the liver is not producing enough albumin Because there's not enough albumin, the blood pressure is not going to be able to suck the excess fluid from the tissues back in to the venous system. And so you're going to start accumulating fluid.
Crazy. A little bit of a lot.
Yes, it does. Yes, it does.
Doesn't it also do itself though?
No, it does not regenerate. Well, let me just clarify. It does regenerate to a point, but you cannot live without the liver. And so even if you have a liver, it's got to be working. But what is so miraculous about the liver is that you don't need the whole liver, that you may have a cirrhosis liver, which will not regenerate. And so you have enough functioning liver to get the job done that you need.
So say you have cirrhosis liver, but it's only like a portion of the liver, they could take that part of the liver out so it doesn't affect the other part of the
They
liver?
probably wouldn't take it out. They'd probably just leave it. Okay, gluconeogenesis. So here we have amino acids which are converted to glucose during episodes of fasting and starvation. Another little thing it does. Now, one of the things about ammonia here is that it converts to urea, which can then be excreted in the urine. So what happens when proteins start to break down is that it causes ammonia. A byproduct is ammonia. So ammonia goes into the liver, it converts it to urea. Urea goes to the kidneys, and the kidney excretes it from the body. All right. So these wonderful little phrases, and can you understand why we use only initials in the lab report? So there are 4 tests that we test for liver enzymes. If we are doing a liver panel, the doctor orders a liver panel, he's going to order specific blood tests, and he'll order an ALT, an AST, and then ALP and a GGT. So let's go back and see what these enzymes do, and you kind of need to know what these enzymes do. So alanine aminotransferase is predominantly found in the liver. And so if that is elevated at all, it's highly indicative of liver dysfunction. Now, an ALT is also found in the kidneys and the heart and the skeletal muscles. But if an ALT is elevated in blood lab work, then we're going to highly suspect liver and go further with liver, because there's just not as much of the ALT that is found in the kidneys, heart, and skeletal muscles if they break down. So then we have aspartate aminotransferase, which is ACT, and this is also found in the heart, the liver, and the skeletal muscles. The alkaline phosphatase is ALP. It's found in many tissues, including the liver, the biliary tract, and the bone. And if this is normal, if this is elevated and this is normal, then it indicates bone disease, and we can move away from the liver and go to the bone and start looking for why that would be occurring. Again, we're gathering data, and as nurses, as anybody in the healthcare teamwork would suspect, we'd want to look at the ALP is elevated and GGT, or if it's just ALP that's elevated and the GGT is normal, because then it tells us which algorithm, which turn of the algorithm we should go. Lab values are a very, very important tool in diagnosing diseases. So this GGT is the highest concentrations are found in the liver, kidney, spleen, and prostate gland. And then if the GGT, remember ALP, this is elevated, GGT is normal, you're going to have bone disease. But if the GGT is elevated and the ALP is elevated, it indicates liver disease. Yeah, so if you have a GGT that's elevated, so I have a little arrow that points upward, and the ALP is elevated, again, it points upward, then that's indicative of liver disease. If the ALP is elevated and the GGT is normal, then you're looking at bone disease. If the GGT is normal, then you're looking at bone disease. So GGT is also an indicator if there has been some alcohol consumption. All right. So remember we were talking about free bilirubin, and we were talking about conjugated bilirubin. If we run the two tests together, we are looking at total bilirubin. So if the indirect bilirubin, what? Wasn't me. I was, never mind. Okay, so if the unconjugated or the free bilirubin is elevated, it is indicative of cirrhosis of the liver because the liver isn't working. Yep. It's going through, the albumin is going through the liver, but the liver isn't doing anything because the hepatocytes are cirrhosed or not working or whatever, diseased. And so obviously it's not going to become conjugated, so it's going to exit the liver as free bilirubin or unconjugated. Now with direct bilirubin, which is conjugated, if it is elevated, then there is elevated because there are gallstones which are blocking the bile duct. So it's gone through the liver. This is what I was trying to say before and totally screwed up. It's gone through the liver. It's fine. Hepatocytes have done their work. It's emptied into the gallbladder. The gallbladder is stimulated to release because some food has gone through the duodenum. And then all of a sudden, or through the duodenal sphincter and landed in the duodenum. So now that common bile duct is stimulated to release. But it can't release because there's a gallstone or some kind of tumor that is blocking it. So what's going to happen? It's going to stay in the blood and it's going to become elevated. Now remember, albumin is one of the proteins that is secreted from the liver. And so if it's decreased, if the level of albumin is low in the blood, it's indicative of liver dysfunction or that malnutrition, the person is starving, is not eating enough. That is what a low albumin level in the blood indicates. Either or. Okay, here's a case study for you guys. Let's just sit back and ingest. So Veronica is scheduled for a liver biopsy. The staff nurse assigned to care for Veronica is to accompany her to the treatment room. Now, when they do a biopsy of the liver, what happens is they do it externally, and they are going to stick a needle in to this lobe of the liver, take a little chunk of liver out, of liver tissue out, and then come and see, put it under a microscope and see how cirrhosed it is, how functioning it is. So we just talked about all these little coagulation things that happen in the liver. So do you think that this is going to be dangerous or not? Mm-hmm. Huge risk for bleeding. Huge risk for bleeding. So what kind of tests are they going to order before they do this liver biopsy? PTT, hemoglobin and hematocrit, definitely, but PTT, PT, INR, bleeding time test. We've got to know or suspect how much is going to bleed. Now, the copper disease that my daughter has and my son has, they have to send the biopsy away. And so the thing about it is to confirm whether or not they have Wilson's disease. It's highly suspected, but it's a very rare disease, and so they have to send the biopsy away. So it's like her bleeding time, if you remember, what is normal bleeding time? 1 to 9 minutes for coagulation, for something to stop bleeding. Hers was 17 minutes. So then it becomes the issue, how bad do we need that biopsy? And this was my argument. Well, let's just start treating her. No, we have to confirm that there is a liver dysfunction, namely Wilson's disease, before we can order medications so that she can take it. And we don't want to start treating it until we know for sure that it's Wilson's disease. Maybe something else. And so they have to do the biopsy. And they are not going to give her one pill until they know for sure what they're treating. Because that pill will be, no matter what it costs, will be absolutely worthless if it's not Wilson's disease. Yeah. Which I'm still not really thoroughly convinced of. All right, so again, I hope you're leaning back, relaxed about this. So, because these are just questions, people. Relax. Everybody relax. Before a liver biopsy, the nurse should check to see that, number one, a compatible donor blood is available. Coagulation studies have been completed. Vital signs have been assessed. All of the above. There you go. All of the above. The nurse assists Veronica to the correct position for the biopsy. Now, you had a picture of that biopsy. I think, who's got a camera on them? Turn around, take a picture of Mark there. He was snuggled down into his vest, dozing. I said relax, not doze. I'm just saying. All right, so you saw the picture of the biopsy before. So which is the best position for the patient to be in? A knee to chin position with the entire back exposed. Recumbent with her right upper abdomen exposed. Lying on the right side with the left upper thoracic area exposed, or supine with the left lateral chest wall exposed. The right side, yes. The liver is found on the upper right quadrant. Is everybody saying that? What did we just talk about? We talked about the high risk for hemorrhage and bleeding. So we actually want them lying on their right side because of pressure. To compress those blood vessels in the liver, put pressure on the liver so that the vessels will be as constricted as absolutely possible as soon as that needle comes out.
How are you going to get to it?
Well, you have to
It
get there.
left upper. Left upper thoracic areas. So they're going to go in like this, all the way across.
No, I don't think they'll go all the way across. Your liver is pretty dang, I mean, it's more than midline.
Liver's on the right side.
Yes.
You're going into the left.
You wouldn't go in through the left. You'd go through the middle. It says with the left upper area exposed, doesn't mean you're going to go through that area.
I don't do that.
Okay. But the point is that you need to recognize this is a highly risky procedure with somebody that has cirrhosis of the liver. And so because of the risk for bleeding. But it needs to be written. Go ahead and tell me to my face. I won't get my feelings hurt.
No, I'm just curious. So you have them lay on their right side even before they take the biopsy, just to restrict blood flow to the liver before the biopsy is taken, and then continuously stay on the right side.
Yes. Yes.
Okay. So they couldn't like get it and then have them roll over.
You probably could do that as well. You probably could do that as well. But you'd have them stay there for as long as possible. Because you got really bad. It does. It's a poor question. Go ahead and tell me to my face. I'll accept it. What do you think out there, cyber people? They're not responding, are they? Okay, after the biopsy, the nurse assists Veronica to ambulate while splinting her incision, assume the Trendelenburg position to prevent post-biopsy shock, Fowler's position in which she can effectively take deep breaths and cough, and the right side lying position with the pillow placed under that one, number 4, yeah. All right, so here's what's going to happen as we actually come into liver failure, which again, to me, is just something that is amazing. So with a normal liver, then the hepatocytes function normally, and but the problem is there's 2 types here that we're talking about. The problem is the liver is unable to fulfill its normal role within the body. So there's something going on there. Perhaps it's hemophilia, where the liver doesn't have all the factors that it needs to coagulate blood. And then the other side, so the hepatocytes are not working correctly. The other side is the portal hypertension here, where you have an obstructive blood flow through the damaged liver. The liver is not being able to flow as fast as it should be because of all these cirrhosed nodules in it. And so what happens here is that you're going to have a backup. And remember we talked about fluid backup in the heart? Well, basically, this is the same thing that we're talking about, is that the portal vein, remember, all these veins from the lower intestinal tract is now dumped into the portal vein. The portal vein is now going through the liver, but because the liver is cirrhosed and has all these little nodules, the blood flow through the liver is not going as fast as it should, 1,000 milliliters per minute, because of all these nodules. So you're going to start having backup. And now, because of the backup, you're going to come up with the systemic congestion. Because if these are starting to back up into the portal vein is starting to back up, then these will start to back up, which means the intestine will start to back up. You'll have backup from the liver. So it just becomes a systemic congestion again. Now, the main causes, for the main causes for cirrhosis of the liver is Leydig's disease or alcoholic cirrhosis. And in the United States, this is the #1 cause for cirrhosis of the liver. I would highly suspect it's true in Russia. I know. But there is also called a post-necrotic cirrhosis that is caused by viral hepatitis. So your hepatitis C is going to cause this. Your hepatitis B is going to cause this. Biliary cirrhosis is caused by an obstruction of that common bile duct. And so you're going to have this back up again into the liver that is going to destroy the hepatocytes. And then you have metabolic cirrhosis, which is not common at all. There you go. So this, we're going to talk about the clinical manifestations or the signs and symptoms of this. So first of all, we're going to talk about jaundice. And we talked about jaundice already. And this poor guy up here is kind of a deeper orange. I don't mind telling you. So when a bilirubin level exceeds 2.5 milligrams per deciliter, then you're going to start seeing the sclera turn yellow, the skin turn yellow. Person is going to not feel good, have fatigue, weakness, headache, fever, chills. When it gets really bad, the person's going to turn a deep orange. There's going to be foamy urine. We've already talked about the clay-colored stools. You think they're going to have heartburn? Yes, they're going to have heartburn. Now, this is a problem. We can't fix it. Cirrhosis liver does not regenerate. So if you start turning yellow like this, a significant part of the liver is not working. It says treat the reason for the jaundice. Now, remember that jaundice that is a result of cirrhosis of the liver is not the same as newborn jaundice.
Oh, so everything like it. Go outside.
Yeah. Okay, so what happens, another clinical manifestation is a person is going to itch like crazy. And that's because bile comes forth into the skin tissues and tissues of the body as a salt. And so it's bile salts that get into the skin and cause you to itch. And people with this will itch until they bleed and keep itching after that. There's nothing really that can help it. Yes, ma'am. Well, the thing about it is that can happen. It can help with the newborn because the newborn has a healthy, although immature liver. But the difference is now we're talking about a cirrhosed liver that is going to keep producing these bile salts and things that cause are the you can't fix a cirrhosed liver. Does that make sense to you? Well, it's like you are treating the symptom, but not the cause. With the newborns, you don't have that issue because it's going to be a healthy liver. And so you get rid of those salts with the newborn by, phototherapy, but then with an adult, it's just going to keep over and over and over.
It can be complicated, but it's not going to be helpful.
Yes. Correct. Whatever working part of the liver is still there will have conjugated. But this is when we're talking about cirrhosis to this point where the liver gets in failure, you have more failed hepatocytes or more non-working hepatocytes than you do working hepatocytes.
Let's read those.
Whatever, it's not going to be 100% free bilirubin. It's going to, there will be some conjugated bilirubin there, because by the time you get 100% of the liver gone, that's when you're dead. So it's just
a majority of the reason why you don't is because it's free bilirubin, right? It's not, the liver's not working to conjugate it.
yeah, that's right. But let's just keep going. I don't know.
Yeah.
Nursing interventions. Avoid soap and perfumed lotions that tend to dry the skin. Use cool rather than warm water on the skin. Use lotions without alcohol base. You know, I've seen this before. This is where you star these notes, because this is going to be on the test somewhere. I don't remember the question, but I sure remember the answer, and that's it right there.
I think you saw it in a patient somewhere. Like, okay, where?
All right, encephalopathy here and coma. So what do you think is a causing the encephalopathy?
Is it hepatic encephalopathy?
What? It's ammonia. Now remember that you have a protein breakdown. Some of the breakdown, the byproduct is going to be ammonia. And ammonia is going to come out of the liver. So if they're doing a liver panel, remember we're doing the ALT, the AST, the GGT, the ALP, liver enzymes, but they're also going to find a bilirubin. We talked about that already, but they're also going to require on their liver panel an ammonia level to see how high that ammonia is. And so that ammonia is what is causing the encephalopathy in the brain. And, the drug that my daughter had in her Wilson's disease is a chelator. So it causes the copper, it attaches to the copper, it goes out of the liver and is excreted in the urine. The only other drug that is much, much cheaper than that is your zinc. And the zinc prevents absorption of copper through the GI tract. So the thing about it is that when you have ammonia like this, then what's going to cause that is that, the ammonia does not convert in the, I hate these long lectures because it's it's more than my mind can handle. So, okay, so ammonia is not excreted from the body in a diseased liver or converted to where it can to urea, which then can be excreted from the kidneys. So it stays ammonia. So then what happens is the ammonia is traveling around. There's high levels of it in blood. It goes up to the brain and causes havoc with the brain. And a person develops encephalopathy. So initially, there are minor mental changes where they may be slightly confused. They may have hyperactive deep tendon reflexes. But one of the tests that they always did with my daughter, every time she went in for a follow-up checkup to make sure the therapy was working, was these asterisks. And what you do is you put your hands out like this, and then the doctor pushes up against them, and then they'll start to tremor if there's high levels of ammonia in the brain or higher than normal. Simple tasks such as writing becomes very difficult. And then as the encephalopathy progresses, then there's going to be a loss of reflexes. Your extremities kind of lose their tone. They become very flaccid. The person will go into a coma and will die shortly afterwards. So, what are we going to do for somebody that has encephalopathy? We're going to treat the causes. Well, can we treat the causes? No. But they did treat the cause with my daughter with a medication. Determining what is causing that liver to fail was high levels of copper. So what are we going to do? We're going to get rid of the copper. That's what they're saying when we remove the causes. Some things you can do. Others, like with alcoholism, yes, you can stop the intake of alcohol, but the damage is still there. You want to have the person eat complete proteins. Lactulose is a antidote, so to speak, for high ammonia levels. So it decreases the pH in the bowel, it decreases the production of ammonia by bacteria, and it also increases water content and self in stools. Oral antibiotics, neomycin, that destroys chronic bacteria and prevents formation of ammonia, which can be associated with liver disease. Gastric section and enemies may be used to decrease blood and GI tract following esophageal bleeds. We'll talk about those in a minute. And they will discontinue any sedatives or opioids. Why? Well, no, because we don't want to sedate an impaired brain anymore than it already is.
Literally just that.
Yes, literally. Monitor mental status and handwriting abilities daily. Do not consume alcohol. Now, one of the things as a nurse, encephalopathy, when it becomes visible, it's almost an immediate thing. So if you see mental changes in your patients, you need to notify the healthcare provider immediately. Okay, so when we talk about albumin, remember that the liver is supposed to secrete albumin, but when the liver's not working, it's not going to secrete albumin, so there's going to be low albumin in the blood. So when there's low albumin, there is going to be low oncotic pressure. So it's not going to bring those fluid back into the vasculature. So it's going to stay in the tissues. They're going to start having edema in the lower extremities, and they're going to have edema in the upper extremities, and then they're going to start accumulating ascites. Now, the thing about that is that ascites can be, it's not going to be resolved, but you can address the symptom of ascites, which is a huge fluid collection in the abdominal cavity. And so we can reduce that accumulation of fluid by providing a diuretic, namely Lasix. So do we want to put them on a potassium sparing? Yes, we do. We want to put them on a spirulactone instead of Lasix, if at all possible, because these people are going to be peeing so much fluid out that it can cause an imbalance in the electrolytes. And if you're going to exacerbate an already bad problem by now putting a dysrhythmia to the heart. So if at all possible, we want to put them on an potassium sparing. My daughter was, and every night she lost 20 pounds. Give her a Lasix. Let me change that. Every night she gained 20 pounds. We put her initially on Lasix and then had to switch to a spironolactone because she was losing too much potassium. But 20 pounds a night. Wake up the next morning, we'd weigh her and she'd be 20 pounds lighter. She looked like she was 9 months pregnant by the end of the day. So, hypoalbuminemia, so there's low albumin in the blood, is going to cause edema in the lower extremities first, then the upper extremities, then you're going to start accumulating ascites. And we resolve that or treat the symptom. Again, we're not curing the disease, we're not treating the disease, we're only treating the symptom by offering diuretics. Person will also have vitamin deficiency. There will be an inadequate formation and storage of vitamins A, C, K, and B complex. The absorption of fat-soluble vitamins A and D and E is going to be impaired. And then we're going to provide them with vitamin supplements. So there's a risk for infection related to impaired immune function. And the earliest warning signs of this is going to be that there's going to be subtle changes to the person's personality and behavior. Remember, I was telling you how my daughter was crying all the time. She didn't know why she was crying. She was just crying. And it's very necessary to be aware of those subtle changes. However, like I said, I just attributed to that she was going to start her menses, so I just kind of discounted it. What a great mom, huh?
How old was she?
She was right before she turned 12. The day she turned 12, she got her liver biopsy.
Happy birthday.
So be very careful to evaluate the white blood cell count. It may or it may not elevate because the white cells activity is impaired for the production of that. And of course, you want to implement infection control. Anemia. So this can be secondary to gastritis. Inadequate dietary intake, impaired formation of white blood cells, and excessive destruction because of the portal hypertension in the spleen. So again, the signs and symptoms of anemia are going to be the same no matter what the cause is. Talked a little bit about that in our hematologic lecture. The signs and symptoms are they're going to be weak, weak, weak. Orthostatic hypotension, syncope, pallor, any of those things are going to be indicative of anemia. So we want to rest there. We want to have periods of rest during the day. We want to sit them up slowly and have them dangle off the side of the bed. Encourage adequate diet and, again, address the underlying cause, which you do the best you can with. Risk for bleeding, we want to implement safety precautions because we don't want them falling at all. They may experience bruising, nosebleeds, bleeds from wounds, GI bleeding. So again, we're going to be doing daily lab work on them. If we see any unusual bleeding or if their gums start to bleed, things that you don't usually see in the person, then you you want to implement fall precautions, any kind of safety measures at all, because they are at risk for bleeding. We also want to administer vitamin K. Vitamin K can be administered IM, as well as taking oral supplements. And there's also going to be metabolic abnormalities that we talked about, which are sometimes rare with liver failure. But when you have liver failure, then there could be fluctuations in the levels of blood glucose. We need to recognize that the metabolisms of medications in the liver are going to be affected because of the diseased liver. And so the clearing of that is going to be decreased. So what do we want to do with the frequency of medication administration or dosing? Exactly. You will time it differently than you would with somebody that had a working liver. It's going to be extended, not as often. So the liver does not properly metabolize hormones, including sex hormones. And so men will have man boobs, basically. They'll have testicular atrophy. They'll have a loss of pubic hair. And then women will have amenorrhea. Look at what I'm doing here. I'm just showing you. May need to know that. Okay, this is your ascites. It's true. It's disgusting. What can I say? She was out of school. My daughter was out of school for a year because the counselors felt like her classmates would make fun of her because she looked like she was pregnant. But it would swell up like this, and then you give her some Lasix or Aldactone, and it'll be down again. And it fills up overnight again. So there's a rapid weight gain, shortness of breath, striae and distended veins are visible. And you'll have, sometimes, she never did, but sometimes you'll have an umbilical hernia there because of the pressure. So for the interventions that we do for ascites, we put them on a dietary modification. We have a low sodium diet, and that should make sense to you. We'll reduce the fluid retention when you have a low sodium diet, because where does water go? Where does food go? It follows salt in the body. They'll put them on diuretics. We talked about that already. Bed rest, daily weights are the most sensitive indicator of fluid retention. Hold on, I'm flipping through my notes here. Another thing you want to do is measure daily weights. I said that already, didn't I? Monitor albumin levels, record intake and output. Paracentesis, what is that? You stick a needle, big bore needle, through the abdominal wall and pull out the excess fluid. Now this TIPS, what is this TIPS? Let's go to the next slide. This is a TIPS procedure. And this is where you'll see right here, over here off this GI tract, you have all these venous venules and veins that are dumping into the portal vein. This is the portal vein that comes and goes through the liver. But what we're going to do now instead of having that venous blood, deoxygenated blood, go through the liver, what we're going to do is connect to the hepatic artery or the hepatic vein, which is going to turn that or dump that into the inferior vena cava, and it's taken back up to the heart. So it doesn't even go through the liver at all. Okay, splenomegaly, this is where you have a greatly enlarged spleen because you're not able to move the volume of blood through the spleen because of the backup from the liver. So when the spleen is not able to do its job, then the person ends up with thrombocytopenia, which means that they don't have a lot of platelets. They end up with anemia, which means they don't have a lot of red blood cells. And they end up with leukopenia, which means they don't have a lot of white blood cells. The final thing that we're going to look at for complication or just the result of this backed up portal hypertension is the fact that, again, you have all this backup of blood from the portal vein. What empties into the portal vein? All the venous blood from the intestinal tract. So what happens here is that these veins in the esophagus get engorged, and you can see how engorged they are here. Look at the size of these. In a normal, I should probably put in a picture here that is normal, picture of a normal esophagus, but this is with engorged veins from the portal hypertension. That's what they call the backup, portal hypertension. So you have these engorged veins here. Well, guess what? I've just eaten a steak. And I've chewed it enough to the point where I can swallow it. Is it fluid yet? No, it's big old chunks of food. So the chunks of food are traveling down this esophagus, and all they have to do is either get caught, not necessarily even a cut, it can brush up against this very superficial engorged vein and cause a bleed, an esophageal bleed. Well, choking, but now you're going to be just bleeding. And blood's going to flow down into your stomach, and it's going to be there. So the thing about it is this is considered an emergent situation, simply because you have this backup of blood that is going to be higher volume than is normal within these veins. And so you can literally bleed to death. And it is considered an emergency. And when that happens, you're going to go into shock. You're going to have a deterioration of mental status really quickly. It's not a good situation. Anything that's emptying, it doesn't have to go up through the intestines. Remember, the veins come off of each portion of the intestinal tract. So the backup is coming from the portal vein, and that can cause the backup of those esophageal, they call them esophageal varices, which is an engorgement of the veins that are emptying the esophagus normally. But now they're backed up, and so if you erode the internal lining, maybe you went to Mexican food. Maybe you went to Orlando's for lunch and had chips, and it runs across that vein and nicks it or nicks the the lumen to the esophagus and pierces that vein. Now you've got blood. And you have a lot of blood. This is huge with alcoholics. As their liver fails and as they develop portal hypertension, they develop these esophageal varices. Okay, so again, it's considered a medical emergency. You want to monitor vital signs for evidence of shock, administer oxygen, do a large bore IV access because we're going to have to be infusing fluid like crazy. Usually what they'll do is put in a urinary catheter to allow for a huge amount of output, because why we're putting in a huge amount of fluid through those IV sites. We want to do endoscopic procedures where we go in. They will go in much like they would do a stent or a balloon. Angioplasty for heart, what they'll do is they'll stick a catheter type device, a Foley catheter type device. It's not a Foley catheter, but it'll be a type of device where they can blow up the balloon and hopefully put on some pressure on some of those veins to get them to constrict and to quit bleeding, stop the bleeding. Of course, you're going to have problems stopping the bleeding because you have coagulation problems because of the very thing that's causing this. So it's not a good thing to be in. They can do a variceal ligation, which is a banding of the esophagus, and sclerotherapy is where they'll inject an agent that thickens and closes the dilated vessels. So here's a case study for us. Joan is scheduled for paracentesis because of ascites formation subsequent to cirrhosis of the liver. The nurse helps Joan to assume the proper position for a paracentesis, which is lying on her left side, a recumbent, so that fluid will not exert pressure on the liver. Recumbent, so that fluid will pool to the lower abdomen. I don't know how that works, actually. Semi-Fowlers to avoid shock and provide the most comfort, and upright with their feet resting on a support so that the puncture site will be readily visible.
I don't know.
Upright with their feet resting on a support so that the puncture site will be readily available. All right, so this is what we're going to do for our learning activity. I know you've been waiting, dying. Oh, there's one more question. After the paracentesis, Joan should be observed for signs of vascular collapse, which include bradycardia, hypotension, oliguria, pallor. Include all of the following except bradycardia. There you go.
Nailed it.
There you go. Any more questions? Let me just, another question. Obstruction of the gastrointestinal tract leads to which finding? Increased peristalsis related to increased force of intestinal contraction, distension above the point of an obstruction, pain and sense of bloating, and all of the above. Everybody agree to that? Well, okay, so what you're having up here, it is all of the above. Increased peristalsis, increased force of intestinal contraction related to. Huh? Well, okay, you have an obstruction here. So what happens when you have a lot of food going through the intestines at once? Are they contracting harder? Are they trying to get the food through? Yes, you do. Well, now you have obstruction. So what happens? proximal to the point of instruction, you start backing up. Well, you get more and more fluid, which fills up the intestinal tract. So again, you're thinking it's food, and it starts. Yeah, so it's trying harder to get it through, and it's not getting through. So here's a question for you, and this happened to the same daughter. Got Wilson's disease. So this happened to the same daughter a year later. No, we're not going to go into that. We don't have time for that. So anyway, when about 4 years ago, she's the one that came up with colon cancer. And so that was diagnosed because the tumor obstructed her colon, totally obstructed. For 3 weeks, she went to the emergency room every Saturday because of the pain and discomfort she was feeling. And during that same 3 weeks, she kept eating. And the tumor was getting bigger. So what do you think happened to that food in the intestinal tract? Backing up, backing up, backing up. Intestines are still working, proximal to the obstruction. Stomach's still working, turning the food into chyme. Chyme's going down through the duodenal sphincter into the duodenum, through the jejunum, through the ileum. Breaking down, breaking down, breaking down. She started to back up. The fluid and the fecal matter from the first part of the small intestine, through the small intestine to the first part of the colon. Got backed up through the pyloric sphincter into her stomach. Making her sick. What do you think happened to her? She threw up shit. And still, she couldn't tell what it was, but she kept gagging and having to throw up, throw up, throw up. And it's green because it's gone through the duodenum, it's gone through the jejunum, it's gone through the ileum, turns the bile green. The bile and the fluid is greenish brown. So they were going to give her an NG tube. They never got it down her because they found out she had a tumor. So that's when they took her to surgery. But she kept getting heartburn and throwing up and throwing up. I know. I didn't tell her for 2 years after the fact because I knew it would make her sick to know that. Yes.
So sad.
The same that got scratched by a rabid bat after we moved to Utah. A rabid bat. Do you know you have rabid bats here in Utah?
Yep.
Okay.
Yes.
Yes. I feel she's related to me, so she's cursed. That's the only explanation I can give her. Huh? Yes, they did. Yeah, and to send it to the University of Utah. She waited 3 days. They told her it was rabid, so she had to go do the injections. I think there were 4 injections at $700 a piece. It was pretty sad.
Should have stayed in Oklahoma.
I know. Okay, so here's what we want to do for our learning activity because I know you're dying for learning activity. So let me show you where it's at and what you're supposed to do and what is due tonight by 11:59 p.m. And all the sleeping people wake up all of a sudden. So I'm going to bring up on your screen, see if they will, people. So let's see. If you go to Canvas, which you probably can't see right now, let me bring it up and see if you can see it. Can the people at home see this? People at home, are you still there? Are you still there? I don't hear anything, so apparently they're not. They fell asleep weeks ago. All right, so if we go down to gastrointestinal unit, Okay, so right here, you have a liver failure case study. Oh, sorry. So this is, I pulled up on Canvas. Can they see it now? Can you see it now? Let me bring this down a little bit. Okay, so here you have your case study. Here you have your answers. Okay. Here's where I contribute my expertise. Fill this out, turn it in by 11:59 tonight, and then tomorrow I will post the answers, which can be utilized for helping you study. Okay? Are we good on that? This is found in the modules on Canvas. We good? 11:59 tonight. Okay, any questions, people? This is difficult. Liver failure, you just need to break down. There's very definitive things that are associated with liver failure, and you need to break those down piece by piece. Okay? All right. That's it, people. I will do a review for you tomorrow while you're in farm, enjoying that exciting, titillating topic. I will be doing a review on this exciting and titillating topic for your review and to help you study. Always, I'm available if needed. I'm in clinicals on Saturdays, so if you want to arrange a time in advance when to do a one-on-one conference call about questions that you may have, feel free to do that. I know that anybody that needs help, please contact us before the test so that we can answer as many of your questions as clearly as I did today.
Hey, Vicki.
And we'll get you through this. It's just, please utilize all the resources that are available to you out there, because all the questions on the test can be found within those resources. All right? All right,
Hey,
go
Vicki.
away. You're dead to me now. I'm stopping this.
Hey, Vicki.